Before this episode properly begins, I'd just like to butt in because today is a very special day. This Thursday is Andrew's 50th birthday. So this episode is very much a happy birthday episode for Andrew. And I just wanted to say, Andrew, thank you. In the time that I've known you, we've become friends and we've worked together. I have learned so much from you, and I'm constantly in awe of your humility, your dedication, and your passion to doing things right to help people. You've helped me learn what it means to be an authentic voice in this space. And I'm truly grateful for all of the information, the help, and the guidance I've had from you. And I know that you have helped countless people on their own journeys and with their children's journeys to understanding their own ADHD and other neurodivergent conditions. It's also important to say that Andrew isn't just an ADHD clinician. He is a husband, a father, and a family man. So Andrew, thank you for everything you do, juggling the practice at Divergence with all of your other endeavors, including this one. This episode very much is for you.
Hello, welcome back. Talk ADHD is back again. And this is probably a timely episode. It is, for most people, only a few weeks into a new academic year. And for parents of children who may or may be wondering if your children are neurodivergent, it comes with a whole host of other questions and challenges. And it doesn't matter whether your child is just starting their academic journey in infant and primary school, or whether you've just, like Andrew has, sent a child off to university. Those questions and those emotions and those challenges may be the same for lots of parents. So in this episode, what we're aiming to do, answer a lot of the questions that in my 15 plus years of trying to be an advocate for other parents, I've been asked over and over and over again by parents at various different stages of the process. So we're going to cover hopefully a lot with Andrew's experience both as a clinician and dad, which I think is a really important thing to impress on you here, that you are talking or you are listening to two parents of neurodivergent children who are both neurodivergent themselves. So we've had the conversations in schools. We've had the challenges maybe that some of you have faced. So this information will be very, very personal and evidence-based, as well as very authentic and real, because we've both lived it. These questions then, like I say, just to contextualize this for you, I know you've got them in front of you, but these are all things I've been asked over and over again. Now, some I've always felt confident to answer. The more I've worked with you, the more some of the answers would have changed. So I'm going to be really interested in where your head goes with some of these. And I'm going to start with one that's come up more times than I care to mention, and that's when parents are at the point of thinking about seeking a diagnosis. Now, I'm going to focus on the ADHD, but I think some of the questions transcend other conditions as well, whether it's autism or dyslexia. We're obviously focusing on what you do in your clinic here. So the question is dead simple. When we're looking at children, what is involved in an assessment through to a diagnosis? And how does it differ in terms of the process for adults?
Nice, simple question again. You always like to start with a nice, simple question, don't you, Matt? I must say, before we start this, I am not a Senko, and my experience is more with adults than children, although I have worked in NHS and independent services with children as well. So you are getting very much a dad plus a clinician answer here. This isn't a comprehensive answer, and maybe we need to speak to a Senko educational psychologist on the podcast in the future. But I thought it was important that we opened up this topic, so that's why we're doing this. So what's involved in an assessment? Now, I can talk through the nuts and bolts of what to expect in the assessment process, but before you start that, there's the journey to that assessment, isn't there? And I think that can be a tricky thing to navigate. It can be tricky because you're told you need to get some input from school, and often school will say, well, we're not seeing any of that, and that can be problematic, you can go to the GP and they say, well, what's school saying? And there has to be, it can be quite a battle just to get to that first assessment appointment. Other things that get in the way are working through the diagnostic criteria. We have to evidence that symptoms are evident in more than one setting. Yeah, we've talked about that on the assessment episode before, and that's the same with children. There's very little difference in the diagnostic criteria between children and adults. Just the number of symptoms that need to be met is the only difference. All the other criteria are the same. But the barrier a lot of people hit is that the symptoms aren't evident in more than one setting. I hear this a lot in clinic, having lots and lots of problems at home, but school are saying everything's fine.
So are there options then? So let's say you're faced with a school that says, we don't see that, they're the model student, and mum and dad are tearing their hair out because the meltdowns are explosive and the challenges at home are huge. What about, for example, if we've got kids who are going to after-school settings or clubs or other groups? Is that evidence?
There's a couple of routes, and there's a very key point that I'd like to make. That you're right with that. It does have to be more than one setting. It doesn't have to be home and school. That's just a nice, easy way of doing it, and that fits nicely. The diagnostic criteria don't need evidence necessarily from school. It has to be in more than one setting. But what the criteria says is that the symptoms have to be evident. The impact of those symptoms has to be evident. That doesn't mean that the child always has to behave in the same way.
Right.
So it's possible that that child who's coming home overwhelmed is really, really struggling and working hard to maintain their focus through the daytime, coming home exhausted. And of course, they're in the safety of their own home, they let fly. Lots of assessments I've done lately have been about this. What's going on at school? Where's the evidence of those symptoms at school that other people aren't seeing? I had one last week where the school did a rating scale for ADHD, and the kid scored better than an average child would on the school's ratings. But actually, we'd done a QB check, and that showed very, very clear ADHD. So what's going on there? What's going on there is the child is wanting to please and working extra hard at school and getting by. In primary school, that's possible, but as that child gets older, they're going to struggle more and more as the academic demands increase. And often there comes a crunch point where things go really wrong. The child disengages from that. It's just not worth putting that effort in any longer, because all I do is go home and shout at mum and dad, and they're upset, and I can't do this anymore, so I'm not going to, and then disengage from education. So I think the message to the parents in that circumstance where they're saying, I'm seeing ADHD at home at school, are saying it's not, is let's think about what's going on at school in a bit more detail, because it doesn't have to be that the child is having meltdowns at school.
Right.
It doesn't have to be a persistence of behaviour. It has to be a persistence of symptoms. And then the impact of those symptoms upon behaviour can vary in different settings, and often does. We have a term for it, masking.
So I've got just to interject on this then. Obviously, my two sons were home educated for 5 years. Now, at the point they were home educated, had we been seeking their diagnosis, that have made it inherently more difficult. I know we're talking about more than one setting, but if they're not in school, what could we have lent on them? Because we've got so many children now who are in education other than at school or are elective home educated because parents have noticed, but that doesn't mean they still might not need that assessment or diagnosis. So what might be an alternative for parents in that situation?
Any setting. Leisure settings, extracurricular activities, brownies, all those sorts of settings, that sort of feedback, that's valid.
That works.
Because the idea is we need to evidence that the symptoms are pervasive across settings. They're not just at home and as a response to the home environment. That's the reason for more than one setting. A lot of services will say, well, we have to have, and I've come across this time and again, we have to have evidence from school. But that relies on schools and teachers being experts in spotting that evidence. And in a classroom full of kids, you're not going to notice the kid that's quietly gazing out the window. That is happening a lot. I think there's a lot going on there. This partially explains the gender differences in diagnostic rates, although you get a lot of this. ADHD in girls is the daydreamer, ADHD in boys is the overactive. I've met overactive girls and I've met daydreamer boys. So yes, the majority sort of fit that cliched stereotype, but there are hyperactive girls and daydreamy boys.
And just one thing, I don't know whether you've seen this, but something I'm having more and more conversations about actually in I suppose, a cultural sense and differences. I've had lots of conversations with parents of kids who are maybe migrants to the UK or where English isn't the first language, where again, because they're not verbally engaging as fluently or as much as their peers in the class, their challenges seem to go missed more. So just because that child is still learning the English language as well as their mother tongue doesn't mean they may not be struggling. But again, for a teacher, they might not notice those difficulties that parents may be seeing at home. And it's almost very similar, I think, to the boys and girls question, isn't it? That it's not about looking at what, I was going to use the word bias then, or what stereotypes tell us ADHD will present like. It's about looking at the whole picture of a child and understanding all of the factors that could be influencing their behaviours and presentations in different settings.
Absolutely. And not every child with ADHD is struggling academically at school. Okay, it isn't an intellectual impairment. No. It's a functional impairment in the range of symptoms of ADHD. Now, I've met lots of amazing and clever people who have ADHD who did okay.
Yeah. Yeah.
And all of them say, well, what would it have been like if I'd had medication back then? And yeah, there would have been an uplift in performance. There would have been, but they did okay. So, just because your child's a straight A student doesn't mean they're not struggling. So if we look into academic performance as the indicator of ADHD, then we're going to miss people.
Yes. Which I suppose neatly answers this question, because I was going to follow on from that first question with what do parents need to know. And I think that's really important, is that when we're researching as parents, and I was guilty of it as well, I use a phrase, we don't know what we don't know in the beginning, right? We don't know where credible information is, where to look. And there is a risk that if we just look at what's presented, for example, on social media, that we tend to only see the extremes on social media. We don't see the middle. We don't see the nuance or the balance. The child, as you say, that's doing okay academically, we don't get that presented. And that isn't thrown up in people's cultural bias, or you don't see that in the Daily Mail articles or in the GMB pieces where it's all woe and extremes. And so often it isn't. So often that's not the case. So I think it is important for parents to try and get as many different sources of information as possible. And hopefully, hearing you say that is really important stuff that parents need to know. It's about looking at symptoms, cause and effect, I suppose, is what comes to mind. And that might not look how we think it should look.
No, it often doesn't. And often I think parents get stuck in this war of trying to put their position across. It's usually the parents who, the kids are doing well at school, they're coming home and just exploding out of the sheer stress of it. It's a challenge to communicate to school that that's happening without expressing frustration, and then school get frustrated because they're saying, well, we don't see that, and then there becomes this argument that isn't actually relevant to the needs of the child. And it's hard as a parent to not fight. And that word fight is used a lot. And we were involved as a family in some research on that, into the experience of people going into people with children going into the diagnostic process. And the word fight came out in that literature because it feels like one, and it can do. This is why I said, when you asked me about assessment, the journey to assessment is tricky in itself.
Yeah, it is.
And it is impacted by all the stakeholders, not just the child and their needs, but school, mum, dad, and they can often be separate views, if not living separately, and maybe step parents involved as well. And it becomes very, very complicated very quickly. And everybody has their opinion, but in the middle of all of that is a little being who's trying to do their best. Often, if they're primary school age, often they're trying to do their best and don't want to upset anybody, which is why they do everything they can to hide those things that are different, that they see their peers in class don't struggle with. They don't want to be seen as different.
I wonder, there's something else just occurred to me on this point. We often hear, and only recently with the Olympics, we've heard again of people like Simone Biles being hailed as this poster girl, if you like, for ADHD. And then we've got lots of other people who've excelled in various things. So Michael Phelps is the other one that tends to get sort of mentioned. But we've got lots of high-performing athletes, particularly, who receive, or later in life sort of are open about their ADHD. And what I've been reflecting recently is that I wonder whether the fact that those children were able to excel so highly at those activities was because it was regulatory for them. It was feeding a need that perhaps pre-diagnosis, pre-medication, pre-everything else, pre-understanding, it fed a need for their brain. And B, that the reason that they then excelled, apart from natural human sort of ability, was that desire, again, that desire to be good, to show that they can, and perhaps was there an element of them actually working harder than everyone else, plus genetics, plus ability, that meant, my God, suddenly we've got this, 5-year-old gymnast who's beating 10-year-olds. I wonder if that happens as well. And again, whether that then becomes something that's worth parents considering and thinking it's not about deficit all the time.
It's not. So the diagnosis is about describing the deficit, but the diagnosis, as we've said time and again on this podcast, is so much more than that. The impact of ADHD extends way beyond those 18 symptoms. And I think any Olympian, whether they have ADHD or not, would tick all those boxes that you've just described. The ADHD is something that Simone Biles has. That is a feature of who she is. Yeah. And probably within that was part of the drive, but I don't think it was her ADHD that led to her being as amazing a gymnast as she is. It's to do with who she is as a whole person and how she was allowed to express that and encouraged to express that.
Yeah.
Because so many kids with ADHD are encouraged to express something that was outside of their grasp.
Yes.
If I was pushed to be a gold medal Olympian gymnast, I wouldn't make it. And I feel awful about myself. If that was the expectation, yeah. So those kids that aren't destined to be Olympians, just desperately trying the best they can. And I think that's true for all children. They want to please, they want to impress adults and say, look, am I making good progress? And the environment in which we ask our children to do that we often use as the evidence that symptoms are impacting in a setting other than home is school. And that school environment is built around the average student. And the majority of kids with ADHD, they're not average students.
Okay, so let's move this a step, I suppose, on a bit. So I'm now going to place us in between recognizing that we might need an assessment, and that bit sort of maybe when we've decided as parents that that's the right route to go down. Talking the way you describe children and the experiences you've had of your own and children you've seen about desperately trying. The question I always get asked is a combination of, or a variant of, should I tell them or how do I tell them? And how do I discuss that we're going to take them to see, quote unquote, a doctor? And how do we discuss what that may mean with children, regardless of their age? And I suppose what I always hear wrapped up in that is, sort of in brackets, without making them feel like they are broken, have done something wrong, etc. So what's your take on that? And take that however you want, dad or clinician or a bit of both.
Take it as a bit of both. And there's a key word in that big, long lead-up question that you asked that I can change and spin it all for you. You don't tell them anything. You ask, you listen. Involve the child from the beginning. They're already struggling. They know they're struggling. Ask them why. What's going on? Get that conversation going on. Don't delude yourself as a parent that your kids aren't looking at social media and seeing this. It's out there. Kids know better than we ever did as kids, and possibly better than we do now as adults, what it's like to be a kid living in this era. It is very different, and they've got access to this information, and we shouldn't be telling children I, as your parent, I'm taking you to the doctor because you have a deficit. You're struggling at school. Tell me what's going on. What happens when you try your maths isn't going so well? What's happening in maths lessons? Are you finding you're staring out the window? Those sorts of questions. And does anybody else in the class do that? Or is just this something that's happening to you? Get them to think about their experience, because if we ask children, they'll tell us. If we tell children, up goes the walls.
Yeah, of course it does.
And that then starts the dialogue, and it sets the scene for the whole journey. I'm taking you to the doctors and you will take tablets. As a clinician, that is a horrific position to be put in by a parent. This one doesn't work. Can you fix it? No, I can't.
Yeah.
But we can work together to help them find a different way through this, because they're struggling. But let's talk to the child.
And I think there's another element to this. You talk about children being more clued up. I want to say this is from a far earlier age than I think some of our listeners may be thinking now. You know, we have got younger children who are seeing things on YouTube and various other places at the ages of 4 and 5 and 6, where they may see these 4 letters ADHD or ASD or autism or whatever it may be. And now we've got a lot of representation in primary educating and TV. You know, we've got programs like Bluey, I heard recently, has got autistic and ADHD characters written into it. And so you're right, from a much younger age, they may be seeing this. But I think there was a really fantastic question in what you said there, which was, does anyone else at school do what you do? Have you noticed anyone else? And it may be that they've got a friend who said they've got this thing, or you know, that gives them a sense of, hold on, you do that as well. So I think you're right. It's really important to trust that your children know themselves, no matter what age they are, to trust that they understand themselves enough to give you information.
Yeah.
Because that will help.
It's the only way to start. If you start being in control, which is, as a parent, what you want to do. You're driven to make things better for the child. Actually, it's got to be with all the way through at whatever age you are, and you start this journey of understanding that it is ADHD.
Yeah.
You've got to have a sense of control, because often it doesn't feel like it is control. I think that's what a lot of the tension in the ADHD community is about. Not feeling a sense of agency and feeling like done to.
Yes. And I think the older children get, you know, I'm thinking now particularly sort of teens, right from, you know, 13 all the way through. What are we striving for when we hit our particularly middle teenage years, right? What is it that we're all fighting? We're striking out. We're trying to figure out our identity and who we are. And if that feels like that identity is being taken from us, and we're being told you're this thing and this is why, and like you say, take this meds, you know, the fight is going to be real somewhere, whether it's obvious or not. There are going to be those teenagers who kind of go, no, screw you, I'm not doing it. You know, I'll decide who I am.
There's a lot of teenagers coming after long waits for their assessment, and in that wait period, they've gone from, yes, I'm struggling with concentrating, got the referral for an ADHD assessment. By the time they get to the ADHD assessment, they've picked up such a reputation because they don't know that it's ADHD, so they're just underperforming at school. I might as well be that kid.
Yeah.
I might as well just be the person you say I am.
Yeah.
And it happens so often. So year 8 to year 11, even 12, it can happen where they just go, I'm not playing this game anymore. I've tried so hard, and all you're doing is criticizing me. You're not understanding me.
Yeah, it's easier not to try.
Yeah.
Okay, so you lead me on to the next question then, and this is where I will ask you to put your clinician head on. And I do know part of your answer to this, I think, because I've experienced it, but let's say we've got to the point, we've got our child, we've had the right conversations, they're accepting of it, you've got them, we've had an assessment and a diagnosis, but maybe even during the process, is there a way clinicians can or perhaps should be supporting parents and children in terms of what they're telling the school at that point? And I'm particularly thinking the point I think must be really difficult if you're at school is titration. It's not that, okay, you've got ADHD, it's that, okay, now for X amount of time, we need you to take this medication that will probably have an effect. And we're not sure what the effect is, but you've got to do it and still go to school or college and still do your best and still, et cetera, et cetera. So how does a clinician help at that point from your perspective?
My perspective, and it's been a hard gained perspective, because I had to understand that teachers, even Senkos, are not ADHD specialists. And I think we so often assume that they are, that they should just know what to do. And some do. You know, some have been on some really good courses that say what the typical ADHD student needs. And a lot of that can be really helpful. But sometimes, often in the titration, schools need a little bit more advice and guidance. And I tend in my practice to write to school and say, this is going on, this is a bit different than the ordinary sort of off-the-shelf ADHD support. But if you do this for this reason, we'll see better outcomes. And supporting school is a way of supporting the child. So it's part of the job, but it's not a part of the job in every service, because they don't have the resources to do that. So everybody says, well, I don't have the resources to do that. I haven't got the time to offer that. Actually, with a little bit of communication, things can be done that schools are willing to do. They just haven't thought of. And it's just about, it's often about communication, Matt, in this sort of interagency working, and sort of the gap between health and education services is often huge for all. You know, often schools' experience of health services and ADHD services is, can you fill out this questionnaire? Can you tell us what they're like in these circumstances? And then they never hear from them again. And what does that communicate to the education provider? And there's this sort of false them and us that's created once again in an argument around this little one who is trying to do their best. Yeah. And actually, if we can communicate better, and I think parents can help with that. If they, you know, you can't as a parent say, oh, well, I'm just going to let that be. I can't. Often as a parent, you are that sort of intermediary. You shouldn't be, but you are. And that the parental role is another role in the support of that child. And if the other adult roles in the support of that child aren't communicating, then as an adult in that support network, I think you've every right to be encouraging that communication.
You do. I'm going back to hearing that word fight again, though. That's where I think a lot of the time it's still that feeling that it's a battle and a fight to get school to pay attention, to take it seriously, to listen to, for example, little Susie starting a new medication. She might seem to be a bit more distracted, or she might seem a bit sleepy, but she's not. So please don't punish. Please be aware that this could be a medication, and let her maybe go out and have 2 minutes fresh air to those kind of conversations you would like to think would be really straightforward. Anyone in the role of supporting a child will go, yes, I realistically can understand how that can be met with, but we don't have time to do that for every child. And there's it's about getting that communication to a point where I suppose to me, it's a reasonable adjustment again, right? It's this thing of, okay, little Susie has this need. What can the school reasonably do that supports her, but doesn't negatively impact on the other 29 students in a class of 30 plus Susie? And by the way, if numbers are correct, at least another 3 or 4 of them have probably got a neurodivergent condition as well. So we're not talking about just, right? So there's a lot of moving parts, isn't there? But the reason I ask, what can you do as a clinician, or what do you feel your role is because I've heard so many wildly varying experiences of parents whose children have had a diagnosis. And you've sort of mentioned this style before, right? I still hear of the assessment to diagnosis process was no more than, congratulations, little Simon's got ADHD, off you toggle with some pills. And parents go, which means? And what do I tell school? And what do I tell, right? Oh, off you go, there's a leaflet, at best. That is certainly not the experience that I've had with, you and my son, right? And I don't think he'd be where he is today if he'd not had that experience, right? He's got more understanding and agency over his ADHD and future through that approach than ever before. And I will say this, my youngest son was NHS diagnosed, yes, during COVID. Yes, it was a very different procedure, But I can tell you without any sort of hint of upsetting anyone, the support, quote unquote, that he received after diagnosis was, there's your medication, we'll review it in a year. Nothing. There was nothing written to school. There was no communication. And we were mid-COVID as well. So there was a lot that could have been said about a kid in titration during COVID and their ability to focus and concentrate and do nothing. Nothing. And so it's been fascinating for me to see differences, or the difference. But I wonder whether, we were at the UCAN conference this year. I wonder whether that's something that becomes more of almost a push to standardize things and get away from certain providers saying, oh, we don't have the resources, we don't have the time. No, hold on. If we're working with children, make the time, make that part of the process.
Yeah, I think these things happen in cycles in healthcare. So I'm old enough to remember the implementation of the Community Care Act. And what happened in the 1990s was a move towards more integration of services working together, which is, and you can't standardize that. It relies on professionalism and it relies on people working together and understanding each other's roles. And sometimes those boundaries get a bit blurry. So that then creates more complex service, which is harder to manage, and therefore the pendulum swings the other way. And this happens in healthcare and other public services a lot. The pendulum swings back and says we need to routinize and standardize things. And when we do that, out come the barriers again. Because we're working with people, there has to be a bit, I think, it's my opinion, that there needs to be a bit of sort of fuzziness at the edges where there is an overlap between what health and education services do, what health and social services do, what education and social services. It should be less standardized, if you like. It needs to be more built and tailored around the individual. So, it's not for every child that I diagnose that I write to the school and say this is going on. Through the assessment process. Where through the assessment process, I get the impression that school aren't managing. That's when I start to say, okay, let's see what we can do.
Seems like blooming common sense to me.
Doesn't it?
Hi, folks, it's Matt. Sorry to butt in, but I'll be really quick. It would really help us if you could take a minute to do a few things to help this podcast reach more people. Wherever you're listening, if you could like it, assuming that you do. If you could subscribe wherever you're choosing to listen to this or watch it. And if you could jump onto the YouTube link and leave a comment about the episode that you've just listened to, Andrew and I would really appreciate it, because that all really helps this podcast reach more people. For now, I'll stop waffling on and we'll get back to it.
Right, on the phrase common sense. That was me doing a segue, that was. Right. You ready for this? Now, I do get asked a lot of questions, and the next set of questions, I make no bones, are predominantly around the misunderstanding about medication and children across all ages. They are perpetuated on social media almost constantly. They are the kind of things that I've seen used as certain creators in an attempt to demonize both ADHD as a condition and certainly medicating children. But they are definitely questions that I get asked time and time again by parents.
Bring it on.
So, deep breath. Let's start with, children and medication, doesn't matter what age. The question that tends to be number one is, but if my child takes this medication, are they going to turn into some kind of a zombie?
There's so much in that question, isn't there? Yes. If you give them enough, some kids will be completely blunted and flat when you give them medication. But if that happens, it's either the wrong medication or you've given them too much. And that is something that can happen. You can give a starting dose of a medication and it can have that impact where the sparkle goes out of the child because of their sensitivity to that medication. Dial that dose back a bit and wow, there you go. I don't know whether you remember the medication episode, that graph, that sort of... There is a sweet spot, and if you go beyond that and move towards that sort of the orange and red side of that spectrum that I have on the medication episode, that's what we're seeing there. So it's that sort of yellow-orange area. That's that sort of zombification It is one of those signs that you've got too much dopamine going on there. So if we're over medicating, then yes, we can see what I think people mean when they say, will it make my child a zombie? However, that doesn't mean that we can't very quickly and very readily learn from that and move it down. So it can happen. Even with tiny doses, we can see a blunting of the child and a loss of who they are. And I think any parent, and lots of parents that I see, say, I don't want that for my child. And I always say, well, neither do I. That's not what I'm here for. That is a sign that it's too strong. We bring it back. So I didn't want to just say, no, of course it won't, because in the majority of cases, no, of course it won't. What kind of twisted profession do people think I'm in, that I want to make their children a zombie? You know, that's not what we're in it for, but that can happen. And I think it's got that sort of response. And what have we, again, social media to thank for that, more than bloody likely. But even if it does, which is rare, that is a sign that we need to revisit things quickly, and very quickly we can turn that around and learn from that experience, because that only has to happen once for us to know that the child is sensitive to medication.
Yeah, just briefly on quickly. And what we're talking about here is a conversation about medication reviews, essentially. Yes, I understand typically there is a difference between reviews during titration and post-titration, right? Once someone's on a working dose. So I see this really as a titration conversation. This is when we're figuring out what med's right, what dose is right, etc. I saw something, without naming anything, I saw something on TV recently where a claim was made that it's taking years for medication reviews. And I just want to address this. This isn't for you to answer. I want to address this. No, it's not.
So it's not.
That was hyperbole. It was misinformation. And frankly, for me, I think it was irresponsible. A medication review is not taking years for anyone. Is it taking a long time for people to get assessments and diagnosis if they sit on the NHS routes? What did we discuss? It could even be for 12 to 15 years. So the answer to that question is yes, that's years. But if you're in titration and you're with a responsible prescriber, there should be, is my experience and understanding, a very regular feedback loop, so that if we're noticing that we've turned little Johnny into a zombie, mom and dad can pick up the phone and go, I don't think this is right. And very quickly we can get the advice to say, dial down or take the necessary steps, right? So I did want to address that, because I think it's very important, again, and this is the role of culture and social media, that sometimes we see things that are said so passionately that are just not right. And that one I think is very important for me to address. And I'm not a clinician, but I just know it does.
Yeah, I am, and I've more to say on that front. So as a clinician who prescribes these drugs to people, when I issue a prescription, I have a level of accountability, not just responsibility, accountability for what happens when those medications are taken. If that child we were just talking about is turned into a zombie because the medication, for all I follow the guidance fine, is turned into that zombie, and that blunting's there and everybody hates it, I'm accountable. And I want to know that that's happening straight away, so that I can advise on what to do about that, so that we can get a better health outcome. I don't want you to just press on for a month, even another day. You know, I can't always answer a message same day, but I have a level of accountability for that. And even when that shifts over to shared care and the GP is prescribing that medicine, that shared care agreement with me as the specialist, I retain that accountability. So every day that someone takes that medication, whatever's prescribed or not available, I am accountable for that. Ultimately, if things go wrong, that's on me. And if I've put up barriers to you accessing my guidance and things go wrong, it's me that has to take the trouble. So clinicians usually are keen to hear that things aren't working out well. I don't want a blow-by-blow account of every dose every day, but if things aren't feeling right, I'd rather answer that on day 2 than on day 28 when there's been another 26 days of pain, because what's that done to that person's relationship with the medication? So, yes, the idea that people have got to wait months, years to see someone to talk about a medication they're prescribed is absolutely preposterous.
I just thought that was important, and it touches on that point. Right, so the next question, will taking stimulant meds either stunt my child's growth or otherwise affect weight growth? And I suppose what they're talking about is physical development.
Yeah, but again, that is in a minority of cases. So we know that stimulants can impact on growth. There's research to show that. But guess what? They can impact on your appetite. They can change what you eat as well. So to say that the drug is doing that directly, there's no research to say that. There is a correlation between these medicines and impaired growth, sometimes in a minority of cases. And no, I can't call to mind a child where that's been a concern, but I know colleagues who have had that concern directly because of the medication. They've been eating fine, but often it is about the impact of the medication on the appetite and therefore the food intake, and therefore not having the nutrients in order to do the growing. But this is why reviews are important. This is why we monitor weight, height, blood pressure, because we're watching all of those indicators. That's why we ask you for that information to do the worrying for you. Because once again, we're accountable. So if we ask you for those readings, you provide them, and little Simon isn't growing, but nobody does anything about that. That sits on our toes. So long as that information's being shared. It should be something that a clinician worries about, but it needn't be something that a parent worries about, because that clinician, with their accountability, will say, I'm sorry, I can't carry on this medication. Little Simon isn't growing. That's as much concern as you should have. Are the clinicians monitoring this? Are they looking at the centiles?
Right. So therefore, I'm going to bring in personal experience to see what your opinion is on this. So our youngest, as I say, was diagnosed smack bang during COVID 2020. We never met a clinician. We had a phone call and a video call for all that we did. And once prescribed, obviously no contact, he was passed under the care of community paediatrics. Now, he started at, what was he, about 5'11", 6 foot, but then he was tall, and a fairly healthy weight. We were, I think, bordering 11 and a half stone. And very quickly, while taking his prescribed stimulant med, we noticed a very significant drop in weight and loss of appetite, which is what it was, caused by, cause and effect. He had no appetite. We understood enough that this was stimulant medication. Right now, it was a trade-off. Were the meds having the effects brain-wise that we were looking for at that point, and how necessary was it, versus his weight loss? The challenge was we didn't get anyone to talk to. If we asked for reviews, we heard nothing. So in the end, it fell to us, and I use the phrase loosely, knowing what we knew then about medication, to make a decision and say, okay, here is a kid who's probably not going to be going on to college anyway. We know what exams he's going to get. It was at that period. You know what? I would prefer that he's a healthy weight and has the energy to do the things he enjoys again, than he continues taking these meds. The caveat on this whole story being he was taking them every day, because we were told after titration that's what he needed. We weren't, he wasn't given any agency. I see you smile. Now I know better. Now I know much better, right? But I think that's important, because there will be lots of parents maybe in that situation. And it comes a bit back to the patriarchy, I suppose, doesn't it? That conversation of, you've been told by doctor and clinician that little Simon should take this every day. So we believe that. We go, all right, then. But we didn't have that contact, because it wasn't available then, to say, we're not happy about this. Now, I would like to think post-COVID, those sort of systems and checks and balances are better. But is it fair to say there could be some differences in the speed of and the efficacy of communication when we're talking local community care, NHS, versus a private practice like yourself?
Absolutely. Absolutely. But I've worked in local NHS services, and if I got that phone call, I would be concerned about that. And it might take me a little longer than it does now to respond to that message. Although the way the work schedule was planned out was different, I would be wanting, even back then, to get in touch and say, look, if this is titration, I'd like you to stick with it a bit longer. He needs some time to get used to the effects of this medication. We need to be looking at making sure that there's a good, healthy breakfast, making sure that once they've worn off, we're getting, we're not telling him off for being a fridge raider, because when the medication wears off, the appetite comes back.
Yeah.
So all of those sorts of tips should be there when we're titrating. But if this is something that emerges once we've stabilized medication, then we need to be looking at what we're doing. Do we need to use something that's shorter acting to give that focus for a shorter time so that there's more time to get food in there? Those sorts of things, those conversations should be happening, and I've had them in NHS services. Yes, I haven't worked in NHS services for a number of years, but I am a clinician, and I can't imagine that they've all abandoned all hope and have put up a wall of receptionist telephony that prevents people getting through. If that's the case, there's a concern, because as someone prescribing these medications, you are accountable, and therefore you should be getting these messages.
Yeah, I'll be very blunt about this. Unfortunately, the experience we had was everything was done via an answer machine. The only method of communication we had was an answering machine for community paediatrics, prescription phone line.
I think in situations like that, write it down. Write a letter. It's amazing how, because that has to be recorded, and it's amazing how powerful that can be. The CQC aren't going to necessarily inspect every answer phone message left, but they will be looking at people's files. And if they see that a parent has written in saying, I'm having problems with these medications, can I have a review? And that's not happening, there's going to be criticism of the service, and you'll be amazed at how quickly people respond to that.
Yeah. All right, I'll take that as a tip. See, knew we should have met you sooner. Okay, right, let's move on to the other, another one that's all the time asked. Is it going to affect their sleep?
Yes, absolutely is. If you take a normal dose, so your standard dose of stimulant medication at bedtime, you will not go to sleep. That's not when you take it, because that's not when you're prescribed it. If you take it in the morning, it's going to work, and it's going to wear off. And for all insomnia is listed as a side effect on all stimulant meds, kind of has to be really, doesn't it? Because it is a stimulant, but it's more active during the day and it clears out at night. Usually, sometimes people metabolize it slowly, and then we do see sort of knock-on effects of sleep. But usually, it's out of the system enough that you can get to sleep without it being too stimulating to keep you awake. Hidden within the NICE guidelines is an acknowledgement that sometimes people can benefit from taking a dose of stimulants at night. So the idea being that it's difficult to settle into sleep because your mind's so busy, and it's just dotting from thing to thing. And I think most parents that are watching this will know exactly what I'm talking about. That all of those excuses is why you can't possibly go to sleep. Well, that's not just done out of devilment by the child. There is an element of that, because all kids do that. But with ADHD as well, there is this very busy mind-wandery thing going on. And if they're taking medication during the day, brains are great at saying, well, now let's make hay while the sun shines. I'm not being held back by this medication. And you get this rebound hyperactivity, which is often mental. And therefore, we can see changes in sleep, but often. And I experienced this myself. When I started meds, my sleep got better.
Yeah.
Because I had a more even, more typical cycle of the day. Yeah. So yes, they do affect sleep, but how they're prescribed should be considering that. And it's not as straightforward as you were taking a stimulant, having insomnia, therefore it's a stimulant that's causing it. There's a lot more complexity to it than that.
Yeah. Does experience play a part into this, Andrew?
I think so, yeah, because it's really comfortable. When you're assessing, there are semi-structured interviews. You can just work through and tick through the box and write down a little note here and there, but it's not the same as a conversational assessment that you would have with someone with a little more experience. It's the same with prescribing. There are the NICE guidelines tell us to do this, then this, then this, and it's fine to work through that. You would be supported as a prescriber to do that, but as you get more experience, you start to say, well, actually, that's step 2 and 3, that's not going to work out well here. I can explain why. Let's go straight. You should be explaining why. You're not going to follow that.
Yeah.
But so long as that's done, and it's a valid explanation, then why not?
Okay. All right, let's move on to another big one every week. Yes, but if my child takes a stimulant, aren't they just going to become an addict?
Yeah. If they take enough of it, but they should take an awful lot, definitely a lot more than prescribed. And I got to tell you something else as well, Matt. There's enough evidence in the literature to say that actually if they don't, they're more likely to become an addict. So the incidence of substance use disorders in unmedicated kids as compared to medicated kids is higher. So if you've ADHD and you don't take medication for ADHD, there's plenty of literature that says you're more likely to turn to other substances to meet that need. And it's more people I assess than not are doing some form of self-medication, either behaviorally or with a substance.
Yeah. Yeah.
And we've talked about that before. So yes, they will, the research says they will prevent addictive behavior, getting stuck in substance use disorders. Yes, they are potentially addictive molecules. Amphetamine, it is also an illicit drug of abuse.
Yeah.
But the doses that are taken are much, much higher. So that's why I flippantly said at the beginning, yes, they'll cause addiction. Eat your prescribed medication, nom, 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 like the Cookie Monster would, then you're going to get addicted to them. But if you take a prescribed dose, actually, even with the longest acting preparation of a stimulant, your body is exposed to that substance for less time than not during the day. So more than half of the day, you're not having the effects of that medication.
Yeah.
So you reset every time that the medication wears off. And because there's that reset there, we're not building that dependence on sustaining things. So it's important to have a break, but you do that every night when you're taking stimulants.
So that follows on to the next question that sort of comes along with that is, but will they cause any other issues into adulthood if we start taking these meds when we're, 5, 6, 7, etc.?
So brains are consistently developing up until about 25, sometimes 30 years old. So on that basis, yes, there's potential for the medications to enhance the underactive pathways to a point that you don't need the medication anymore to be able to sustain your focus and concentration. So the issue that can be caused by medications is, to some degree, an easing of the symptoms of ADHD without medication, because we're encouraging this developing brain to use these pre-medication underactive pathways more. By doing that, we make more connections, just like a path in the woods, where a well-trodden path is much more likely to be used than one that's one issue that it's not been directly, the longitudinal studies they haven't been done to show that, but the theory is there, and it makes sense that within what we do know, what the science does tell us, that would follow. They came close with some research in atomoxetine years and years ago that was starting to point towards evidence that this is the case. And then atomoxetine went generic, and it wasn't in the drug company's interest to pursue that any longer. So they just left it at, we still see improvements at 6 months.
So I suppose as dad, my question is then, okay, is important rather to frame that by saying, if we start as a child, we are starting that journey we've spoken about hundreds of times of pills and skills, right? So by starting young and having an ability to learn the new skills and learn different coping mechanisms and learn what our brain can function like, it stands to reason then that it's okay as brains develop and we get into adulthood that we may go, actually, I don't feel I need this. And we've said this again lots. I don't need this every day. I don't need this every week. There may be times where I go, that focus, that clarity, that whatever that I know I get if I take meds I need, but I don't need it every day. And that's okay. That's a positive result to me. It's not a negative. I suppose the question, or a different way of asking it when we say issues, is you hear people have made claims about long-term heart issues, long-term sort of blood pressure issues because we're taking stimulant meds. Now, My understanding is I've seen no research that backs that up over a longitudinal study. But have you seen anything about those particularly?
No, because it hasn't been done. What's been done is those naturalistic observation studies that I talk about so many times, the Scandinavian studies that look at people who take ADHD meds, people who don't, and what happens in the long term with them. And we know that if you don't take ADHD meds in the long term, your life is more stressful and you're more likely to have heart problems. Yes, there are risks if you have a genetic vulnerability to certain heart problems, but they should be considered prior to prescribing, and they should be the monitoring should be there anyway if the risk is being taken. So you should know about that.
Yeah.
So the risk, again, so long as the genetic risk has been accounted for, is not taking medication, not the taking of it. So that is why in titration we ask for blood pressure, pulse readings, because we're looking at what is the impact of that medication on the heart. Because if we're going to ask that to be done long term, we don't want a huge increase in blood pressure, but some is okay. That's tolerable. Yeah. So that the reason for asking for blood pressure is about, is this going to be safe in the long term? It's not, oh, Mike, your blood pressure is 141 over 91. We've got to stop the medication. It's if we leave your blood pressure at 141 over 91 long term, you are at a higher risk of heart disease.
Of course.
But if we can see that come down and sustain the medication, then you're at a lower risk of heart disease by staying on the medication and coming off.
Yeah. Now, we've mentioned titration a couple of times today, so I'm going to ask you this to sort of wrap up the questions. I hear lots of parents who struggle to help their kids of all ages understand what titration is and why it's important that they take this medication on a fairly consistent basis for a period of time. Now, that's typically, I see it based around anxiety about what will they do, what will they cause, will it change me? But and again, this is a clinician/dad question now, I suppose. How would you frame it? What's titration? Why is it important? And how do we help kids?
Okay. So at the beginning of a titration, we've made a diagnosis. We're saying that medication is the right thing to do. Now, NICE guidance says that we should do other things first, or at least ensure that they've been done. It's more skills-based stuff, more talking stuff. As long as that's done, then we move to a medication. At that point, I will usually revisit, why did you want the diagnosis? What are the problems that you were saying you wanted help with? And relate the impact of the medication to that. But say that it's a journey to find the right dose. So often that first dose of medication is like, whoa, this is how people think. No wonder people find life easier than I've been finding it on that first dose. But then the second dose, it's not as good, and the third dose is not as good. And then we have to increase it a bit and we see the same pattern again. And then the next time, perhaps, when we find that right dose, it just sustains that effect. So on day 3, 4, 5, it still works the same. That's when we know we found the right dose. And it's important that the lower doses are taken, because if you just took the right dose straight away, it'll make you into a zombie. We need to get the body used to processing it. So it's about teaching the body how to process it. So I will, when I'm starting someone on medication, I'll say, you need to be taking this every day at the moment. Yes, you will have heard that you don't have to take it every day, and you don't. But while we're finding out what this does and finding the dose that we're looking for you, I need you to take it every day, maybe one day a week off if you really need to, but we need to get your body used to processing it. That's my pitch. There's also a bit about getting used to that and getting used to medication in your life. If you only do it as and when, it becomes more like a paracetamol that you take when you've really got a very bad headache, but you'll muddle through if you've just got a little headache. So it's about setting the routine of having medication, because it is a big change for a child to get used to. And I will explain that's a process that helps me more quickly find the right medication for you. If you chop and change, it's a lot more difficult to know what's the medication and what's not. If you're not consistent with anything, it's more difficult to do science around it. Yeah, so I will pitch it as science as well. So if someone's struggling with it, I'll appeal to their inquisitive nature and get them to do stuff around it, sort of observations or whatever, to engage them in that process. What I always also say is this is not a medication for school, because I've seen too many 16-year-olds get their GCSE results and go, well, I don't need that medication anymore. Then you're setting yourself up to fail if you think that you take medication for school. You do not, as a child, just as much as an adult who doesn't take medication for work. You take medication for yourself to improve your focus and concentration. And when you're tidying your bedroom or you're going to see a film with your friends and having fun, you need to be able to concentrate as well. It isn't just about getting your maths homework done. It's about being able to sit and enjoy a new Spider-Man film. It's about being able, when your mum says tidy your room, to not be overwhelmed by the million different tasks you see all at once and just paralyzed into doing nothing. So it's about that whole beginning of the journey is about setting the scene for what this is, setting the expectations, because people have lots of expectations of medication that somehow a medication for ADHD makes ADHD go away, and it doesn't.
Yeah.
It helps.
And again, I suppose this comes back to the availability of content on social media. Because again, I spoke to numbers of particularly sort of teens now, 14 through to son's age, 19, 20, and they see all of these medication diaries, medication journeys online, and typically they're all the very stereotype, generic, oh my God, I took it and this is what it's like and it's amazing. And yet I've met multiple teens, multiple kids who've taken meds and gone, I didn't notice anything. Because that's what their interpretation is. They didn't get that big sort of crescendo, that big wow. I mean, I've met plenty who've taken their meds and they don't know that what they did was fell asleep for hours. And you've got to go, tell me it didn't do anything. Okay, fine. But, that's not what they were looking for. And I think it's, again, I wonder as a clinician, is it harder or is it important for you to maybe know what perhaps they've seen, what they think they know a med should do?
So it's about setting those expectations and putting a bit of humour in it as well. If you're wanting that dramatic head change, you need to see somebody who's going to give you a different kind of amphetamine and do that illegally away from me. Because we're not looking for dramatic head changes. We're looking for significant functional changes so that you can do you better. And that doesn't, I said just then that first dose can be like a significant, overwhelming impact, but it can equally not make any difference and not be felt. And that's often, I think it's better if medication isn't felt. You shouldn't feel like you're on something when you take an ADHD medication. You should feel that you can concentrate better, that you're not moving around as much. And that doesn't necessarily mean that you're going to want to put a set of white gloves on, get your glow sticks and go down a railway arch. That's not what we're about here.
Google it, teenagers. Just Google it. That's fine. Okay, no, you're right. But I do take your point. It's expectation setting, isn't it?
Yeah.
Right. Okay. So what we have done there is answer a lot of the questions that I get asked, and I'm throwing over to you, Andrew, and hopefully to everyone listening, whether you are a parent, whether you know parents at the start of their journey or going through this, these questions and answers will help you. I think it's important that we as parents are allowed to ask questions. It's important that we feel that we work with the right people. We are in front of the right clinicians who give us that ability to not feel stupid for asking questions to things that we are worrying about and don't know about. But I do think this is that conversation again about take your information from lots of sources, not just the one that your workmate recommended or Dave down the pub said, oh, I've seen this. Look at lots, find lots of information and be wary, right? Be wary if it feels like hyperbole. Generally, in my experience, it's hyperbole. If it feels like someone's opinion and you can't find any way of verifying that, you're probably going to be right on that assumption. So look for the evidence, look for people, which is why, having this conversation with you is important. So my last question for you, Andrew, on that is, if you could give one piece of advice here to parents, whatever age their kids are, whatever stage of the journey they're at, what's that piece of advice you would give them to maybe just make them feel like this is how you can cope as a family better?
So I was taken back to that word fight. And this research I was talking about earlier, because it is a fight, but that doesn't mean you need to don knuckle dusters and launch into for all and out war. It's a fight of asserting yourself and enabling communication, and that is something that you're able to work on as an individual. So you can encourage different professionals to talk to each other, school, CAMS services, other parents, be an enabler of communication rather than a warrior. I think that's the genuine fight. So of all of the things we've talked about, we can make sort of flippant comments about medications a lot, and that is useful. But I think as a parent who has engaged with many different schools, really, really good ones, and some not so, in terms of response to what I was saying as a parent our children needed, the art of enabling communication and not being combative about it is probably the most useful tip I can give you, because services aren't perfect. No service is perfect. Some are better than others, and some will hide behind a wall of telephony. And that is where the fight comes in, Matt. That's where asserting is really important. But as much as that's the fight is also working with that parental drive to tell your child what to do rather than ask them what they need, and finding that balance. So I think being a parent of an ND child takes a lot of learning about yourself and how you communicate. And often we struggle with that because we're ND ourselves.
Look, and isn't that why, one of the most common things I know you probably see in clinic, and I see all the time, is when parents are going through that journey at whatever stage, it's also when they start to look in the mirror and go, oh, that's why. And then there's a whole new layer of comprehension and dealing with and emotion as well. So I think it is important, isn't it, to give yourself some space and to know this isn't going to be, you're not going to have all the answers straight away, but advocacy for yourself. And like you say, trying to get the best lines of communication is always going to help more. And I know I've said it before and I will say it again. Whoever it is, whatever stage of the journey it is, if you can find your tribe and help your child find theirs, the other kids like them, so they don't feel so different, so alone, and neither do you as parents, it makes a huge difference. It makes a huge difference just to think, I'm not on this one on my own, because I don't know about you, but it can feel very isolating, when you're in that mode of a fight.
Yeah, it can.
Folks, I hope that's helped. We discussed earlier on briefly university. I'm sure we'll delve into university, and for everyone that's got young adults starting university like you this week and last, Andrew, I wish them all the very best and all the success in the world. And it comes back to communication. I'm sure most of them will be thoroughly enjoying what first year university has to offer, and second and third, and for that matter. But keep the communication open, keep talking to them, and I guess the most important thing is keep listening to them. Keep listening to all the information, because it's a bit like you said about sometimes it's not obvious because they seem to be doing well, that there's a struggle. Keep listening to all the information, and yes, get good at perhaps reading between the lines, because therein might be more information than there is jumping out of the page. Yeah, keep talking, and I hope everyone is doing fantastically. But for now, we will leave that there and see you for another episode of Talk ADHD next Thursday.